Hello everyone, hello and welcome to aidsmapLIVE. Can we end HIV transmission by 2030? I'm thrilled to be joined by an absolutely brilliant panel and an audience from Copenhagen today. Hello, Copenhagen.
Very Eurovision.
it is so Eurovision today. So let me introduce you to everyone, but do please get your questions over and I will pose them to our audience. But first of all, we have fabulous Deborah Gold, who literally has just turned up about 2 minutes.
I'm not pressed.
Deborah is the Chief Exec of the National AIDS Trust, the UK's HIV rights charity, and NAT is part of the HIV Commission that has played a huge role in persuading the government to spend so much on HIV prevention at the moment. So hello and welcome, Deborah. Are you feeling more relaxed?
I am. I'm looking forward to it.
Fantastic, thank you. Next we have Dr. Sanjay Bhagani, an HIV consultant and honorary senior lecturer at the Royal Free Hospital, as well as president of the European AIDS Clinical Society, and also a trustee of aidsmap. Brilliant charity, everyone. Check it out. How are you today?
Amazing, and thank you for inviting me to be here with you.
Wonderful to have you.
Fantastic.
Next we have Ian Jackson, Commissioning Director for Specialised Commissioning at NHS England, who also leads Fast Track Cities London and is the Programme Director of the rollout of HIV and hepatitis testing in 28 London emergency hospitals. Is that correct?
That's correct. Thank you so much for inviting me. I'm looking forward to it.
Thank you. And you have brought the Danish delegation with you.
I have the Copenhagen delegation from their fast track cities, so we're doing a bit of a cultural exchange on HIV.
Fantastic. Well, thank you for joining us. Next we have Dwayne-Wilson Hunt, also known as D. Is that right? We just had a long discussion about which name to call you.
Very long-winded.
Yeah.
Sorry. Yeah.
But I think I'm going to like both. Just going to like.
I'll answer to everything.
Fantastic.
Pronouns she, her, whatever
Excellent,
you want to call me.
Brilliant.
It's all good.
So Dwayne/D is charge nurse at St Stephen's Centre, the HIV clinics at Chelsea and Westminster, and is chair of the Racially Minoritized Community Special Interest Group of the British Association of Sexual Health and HIV, also known as BASH.
Yes.
And you have come on a foldable. You didn't come on the fold. It wasn't foldable when you.
No, it was unfolded, but I protect the environment, climate change, etc.
Fantastic.
It is electric, so I'm not going to say that was all me. But,
I was so impressed for a while.
I know, try.
Fantastic. Next, we have Alid Osborne, Community Engagement Manager at the fabulous HIV charity Brigstowe, co-chair of Tackling Stigma Workstream of Bristol. Fast Track Cities, London isn't the only Fast Track Cities yeah.
But did you bring Danish?
Yeah, wait, so where's your, have you got a delegation?
They're all online.
Oh. Okay, fantastic. And you're also on their steering committee. You have 10 years of lived experience with HIV. I remember when you were a baby activist at the Youth Stop AIDS.
Baby activist. When you fed me, I had breakfast at Susan's house. Susan made me breakfast, and still now it's like ultimate top tier goals.
Wonderful.
The
Fantastic.
pancakes were incredible.
Fantastic.
Susan, thank you so much.
Well, you were a very cute baby activist. Now look at you, all grown up.
A professional, some
Yeah,
may say.
right.
Is he being paid to be here?
Yeah, well.
Yes. I'm only in camera when I'm being paid.
And also, you're a drag queen in your spare time. What's your drag queen name?
Miss Beaver.
Oh, like the British HIV Association.
It's spelled
Beaver.
like the animal, but my ultimate mission is to get the hashtag Beaver at Beaver trending. So anybody at Beaver watching, book me.
Yeah.
Because I'm usually there anyway, so yeah, it's fun.
Fantastic. Well, welcome, Miss Beaver.
Thank you very much, Susan.
Finally, we have the absolute glorious Aisha-monic, who leads the project of community Common Ambition Bristol to address inequalities in sexual health. But you worked in sexual health for 7 years plus.
Feels like a long time.
Absolutely. I think I knew you when you were a baby activist as
Yeah.
well. Look at everyone all grown up. So an activist, plus-size model, and what's really exciting, an international beauty queen.
Oh. I know, right?
So what have you, were you Miss Wales?
So I was Miss Voluptuous Wales, and then I was Miss Voluptuous Cymru, which is a title I technically still hold.
Fantastic. So we don't want anyone taking that title. That is very cool. So thank you all very much. Thank you for everyone who's already sent questions over. So let's get to it. So the UK government has committed to achieving 0 new HIV infections in England by 2030, and HIV testing has played a really important part in that strategy. Sanjay, why is testing so important as we try to get to 0?
So, Susan, testing is part of our combination prevention strategy. In other words, if we want to prevent new infections, we've got to stop people transmitting infection. And the way we do that is to diagnose infection early, link them into treatment, get them treated, get them undetectable. And remember, undetectable is untransmissible. And this is really crucial. And that's why testing remains one of the cornerstones of what we do in our kind of combination prevention strategy.
Fantastic. And Ian, you've played a really important role in getting opt-out testing in HIV emergency departments. What's been the impact so far?
Well, the numbers that we're seeing are pretty extraordinary. But I mean, I've only played an impact in rolling it out. So it's really important all the time to acknowledge that it was the charity sector that lobbied for HIV opt-out testing, along with the medical sector. It was Deborah and others. Well, it's true.
Yeah.
It's really important for us to acknowledge that we're only part of that bigger system. But we've got a 100 days report being published shortly. But I can tell you we found over 100 brand new diagnoses of HIV, and on top of that we've had several hundred hepatitis diagnoses, because we're testing for HIV and hepatitis B and hepatitis C, various stages of rollout. But it's really pleasing that all 28 emergency departments in London are now testing, doing opt-out testing for HIV, and every single person we pick up is a potential to help change a life. And then we hook those people back into, obviously we provide medical care, but we hook them back into the community, who are really good at providing the follow-up care that we need. So it's an amazing project to be part of. Everyone's hugely enthusiastic about it, and it's going touch wood pretty well at the moment. Yeah.
Fantastic. And are you seeing the impact in your hospital?
Oh, absolutely. And we've had at least a dozen new infections over the last few months, and people that you wouldn't have picked up in any other way. And so this is really great news, and it's also great news, Ian, that we're thinking about viral hepatitis in addition to HIV. In other words, we're looking at this as a blood-borne virus strategy rather than an HIV strategy. So this has been fantastic work, and I have to say kudos to all of you and your colleagues, and all of those in the third sector who've made this come along.
Fantastic. And are you seeing an impact in Chelsea and Westminster?
Yeah, definitely, which is good. So, because not everyone accesses healthcare via the sexual health or HIV clinic route, so people might just touch on A&E. So it's perfect. It's a great opportunity to pick up new diagnoses.
Fantastic.
That's why it's so. I'm jumping in.
Yeah. So Debbie, why is it important to expand? Why is it important to expand it, Debbie?
We're like a hive mind.
Yes.
Well, I was just going to say that's why it's so important, because if testing is so crucial to make us meet 2030, the bit that we're already doing right is kind of those members of communities that kind of know that they're at risk of HIV, and they know that they need to test. So, many gay men I'm not going to say all of them, but know to test regularly. Maybe they're engaged with their sexual health clinic. That's part of their kind of system of healthcare. But there's people from other communities that they're not aware that they're at risk. There's such high levels of stigma that prevent them from being able to test. And so by kind of taking the testing to places that people are going, we're going to find people that we wouldn't find in other ways. And the other really incredible, without giving away a figure in advance of the report being published, but as well as finding those more than 100 people that didn't know they have HIV, we've been finding people who have previously been diagnosed but fallen out of care. Right. So that means they're at risk of being incredibly sick and need help and support, and also they're able to pass HIV on. And so it's both those things together that are going to play such an important part.
Fantastic.
And that's why it's so important to expand it. I think, London and Birmingham, Brighton, Blackpool, not Birmingham, sorry, Manchester, Brighton, Blackpool are the kind of proof of concept. And they're the very high prevalence areas. But in a way, the areas with lower prevalence of HIV almost need it more. I say Bristol.
No, agreed.
Because it's even harder to do anything at scale in those areas. But it means that those people that are living with HIV that don't realise they're at risk, they're less likely to come up against opportunities to see messaging for them. This is just a really great way of helping find those people.
Absolutely.
Can I ask, is there any plans to roll out in GP services? Because obviously you have a group amount of people who access A&Es. But what if you never need to go to the emergency room?
GPs are the holy grail.
Yeah,
I know,
but if there was someone that can do that, yes.
I did have a conversation with Ian recently where I'm like, you are a problem solver in the NHS. Let me talk to you about GPs.
We will be coming to you, Ian, to sort that out.
There's a lot of structural problems in the NHS that make it really hard.
Okay.
So
And Aled, how do you use your platform as someone living openly with HIV to persuade people to test?
Sitting on a panel like this and going, please roll it out to high prevalent areas. That's the call to NHS wider, because it's, the biggest thing for me is just ensuring that this action plan that we have is a national action plan and not a London or a very high prevalence area action plan. Because we have got those pockets in other cities where there's either low prevalence, but even in those low prevalent, those high prevalence areas, you'll have very high prevalent hotspots. And when we have so many close areas that South Gloss and North Somerset are right next door to Bristol. But if you are if you're going out on a night out, you're going to go to Bristol. You're going to go and have all of your social activities in the city, which is 10 minutes on a bus. Basically, you cross the pavement, you're in a high prevalence area. So we just need to look at them. But I kind of use my platform all the time, basically. If that's sharing a link to get a monkeypox vaccine to the community because the sexual health clinic isn't reaching them.
We will come to that.
Or whether it's just whether it's in my drag and I do it on stage, or whether it's just in life. I've got to that point now where I'm everybody's walking Google for sexual health in Bristol. And I could be on a night out having a cheeky little gin and tonic outside a bar, and they're like, Alid, I have a question. And I'm like, right, okay, this is either going to be about booking me for drag or you've got something wrong. You've got something wrong with you. And we go around the side and they're like, where can I go and get a test? And I'm like, okay, here we go.
Fantastic. And Aisha, how are you persuading people from black communities to test with your work at Common Ambition Bristol?
We're trying lots of different ways. I think that, we've already made the point about the fact that it's difficult sometimes to get people who would not necessarily engage with sexual health services to know that sexual health services are for them. But also, I think, to know all of the prevention strategies in terms of knowing about PrEP and knowing about treatment and as prevention, that kind of thing. So we're trying really hard to engage the community as much as possible in Bristol. It's been not as hard as people would have thought it was before Common Ambition Bristol was set up. We are going out, we're doing barbershop outreach, we're doing engagement events. We've just created a film that has been shown, HIV Talk, Test, Protect. So that is being shown everywhere now. So it's just about doing the work with the community and engaging the community, I think, in letting them know what's out there for them. I think that so far, not only have the African and Caribbean heritage communities been left behind when it comes to messaging, particularly around PrEP. We know that's a problem in the sector. We know that's been an issue. But I think that also we've been very much in the sector making, making campaigns and stuff and kind of making them for gay communities and then quickly tailoring them at the end for black communities. And I don't think that works. Common Ambition Bristol specifically tries to get the messaging created with and for those communities to make sure that they realise that, no longer are we left behind and no longer is that okay. It's really important for us to do that and to also engage all of our community, all intersectionality. So we're trying to get women talking about HIV as much as we're trying to get men, young people, older people. It's just about bringing the whole community in, really.
And absolutely, and
sorry.
Yes.
I was just going to say, but I think with your project and what you've done really well, which is translatable across the board, is that you involve those communities from the start, from inception. So they've helped design the campaigns, the service, the programme of Common Ambition. They've been there from the very beginning. Yeah. It hasn't been, we need to do a project for this community, we think this is going to work, and then consult, and then do it as an afterthought and go, oh, we should really have some community input here. Your community input has been there from literal inception. Before we even applied for the grant that funded the project, we had community engagement.
Fantastic. And Dee, why do you think people from black communities are more likely to be diagnosed late with HIV?
I think it kind of comes on to what Aisha's talking about, is that when you look at, say, the ACT UP documentary from the 90s, there was a lack of black faces, Latin faces. So I think if you're creating services and tailoring services, if you don't see people that look like you, why are you going to access them? And why are you going to think, oh, that's going to affect me? When you look at all the literature and adverts on TV and you see that it's about Ethiopians and all this stuff, and it's like, why would I want to? But then I guess the migration as well, it's about people here illegally and not knowing that they can access sexual health and HIV and testing for free and not have to worry that they're going to get deported or anything like that. But yeah, and I think massively it's just about representation and being seen, and not just being seen in services that are being created, but also being seen in the services. So seeing people like me, like Aisha, like different coloured skins, being like, I'm one of you, talk to me openly, and not just a sea of white faces.
Absolutely, that's such a good point. And Aisha, in terms of encouraging women to test, what else can we be doing?
I think that it's really about opening conversations, and I think that we kind of need to do a bit of reframing the narrative, if that makes sense. I think that, so far when we talk about HIV, it's about, oh, you need to take this medication, or you need to do that, or you need to do this. But I think it's also now about reframing it and talking about it as part of your normal sexual health thing that you would do naturally. We need to start talking about sex and sexual health in terms of pleasure and all the good things that come with it, instead of it just being about the negative side of things and this is something that you will get that we will have to treat you for. I think it's about opening conversations, particularly with women, like I said, about pleasure, about consent, about how to negotiate conversations as women, how to realise that PrEP works for us for many reasons, particularly within African and Caribbean heritage communities, which I always talk about because that's what I do best. But I think it's just about making sure that we're treating HIV prevention and sexual health in general as something that we all need to be doing, just part and course of what we do. We're all here because somebody has sex, and eventually most of us are going to be having sex ourselves. So educate ourselves on, at some point. But educate yourselves on how to best look after yourself and look after your lover, and just look after your life in general,
Yeah, absolutely.
Yeah,
of course.
So I guess also it comes down to research. It's like, I think there's a long history of black bodies in Africa being used for research, so people are reluctant to continue going to research or accessing sexual health services. And I think it's still, I know it's still happening to this day, that certain pharma companies are going to African countries, doing all the testing and then coming over here and using the research on the Western population. But then also when you go to the Western population, you've got black African women being left out of the PrEP impact trial, being left out of phase 1 of the injectables trial. Like, imagine being a black African woman and being able to have an injectable PrEP and not have to worry that the stigma associated with that disease is going to affect you, because no one will know that you're preventing HIV.
Yeah, very good point. If I can turn to you, Ian, what work are you doing in fast-track cities to encourage people in in partnership with the community to encourage testing?
Well, it kind of goes back to the theme of tonight, which is how do you get to elimination by 2030? And the answer to that is not that me and people who look like me sit in a room and go, we do it like this. But the answer is you go to the community and you go, can you try things? And so for in London, that's meant that we've had an improvement collaborative of 12 projects who've been funded for 3 years. It's just runs to April this year, and we've adopted a quality improvement methodology, which was a little bit sort of foreign to some of those organisations, some quite small charities. But the idea of it was, well, try something to get to elimination. Our numbers are very good against, you know, the international targets, but no one knows how to eliminate. No one's done it yet. So what as the community can you do as an idea, and try an idea, and if the idea doesn't work, try something else. And we won't defund you. We'll just continue to fund something. I mean, you run one of those projects and you're involved in 2 or 3 of them. But again, talking about minoritized communities, we deliberately made sure when we picked those 12 projects that there was enough representation from all of the different, so older women, black-led charities, and so we didn't default to who can write the best pitch for a bid. We had to really get into those communities in a different way, and not only have we got the results of those different projects around loneliness, around living with menopause, around peer support. So some of that now is we're looking to try and normalise if we can get a future funding round, which is where again, there's a big fingers crossed on that. Because by having that 3 years worth of data and those 3 years worth of projects, there's a couple of things that happen. One is the results of the projects, but the other is we have built a trusted community, I think, in London, so that when we approach it again and go, okay, well, that's got us further, and now we've got opt-out testing, and now we've got and now we've got more prep, and now we're in a different position to the one we're in, and it's a better position, which is rare to say post-COVID, but we're in a better position than we were 3 years ago. So how do we do it again? How do we get even closer to elimination? And what could that bring? But the other piece of this is that the thing that I think you guys don't give yourselves enough credit for, and I say this all the time, is that you are the touchstone specialty for how to treat people. And that is not about how you treat a condition. This is about what ails people. Are they lonely? Are they depressed? Are they? What is it about their lives that is causing them maybe not to medicate? And if you can treat that, that is I think the holy grail for how we should look at doing medicine across other specialties, and that's where these projects can also have an impact.
And I think that's important in terms of prevention as well. It's not just about how do you get people to test, it's about what is stopping people from testing. How do we bring testing to the people as opposed to sitting behind our clinic doors and expecting people to come in? Common Ambition Bristol is a perfect example of that. We had to create a clinic outside of the clinic that people knew was for them, and it's taken a long time for us to get the numbers, but now people are really starting to come into that clinic, and we're starting people on prep within that clinic, and we're opening conversations that wouldn't have happened previously. And I think that that's what it's about. It's about using your community services. It's about co-production with communities, with health services, with sexual health clinics. It's about what can you do for your city that's really going to work to help us to achieve 2030.
I think there's an addition to that. It's also making sure there are black and brown faces in your positions, because I think there's a massive lack of black and brown people at senior positions. And it seems to be that let's put this funding, let's go to the community, let's ask the community, like Common Ambitions, to sort out, lots of black women, lots of black people sorting this problem out. But it's like, well, bring us into the commissioner room, bring us into those seats, allow us to have those voices. It shouldn't just be a hierarchy of white-led faces talking about black and brown people and HIV. And that's, I think, a massive issue that we have, that people who look like me aren't in positions.
Thank you for raising that. And getting people on treatment is hugely important in terms of getting to zero. But people fall out of care for a variety of reasons. How can we get people back into care?
So this is one of the cruxes of issues that we need to solve. In other words, how do we find those people that have fallen out of care, and what can we do to bring them back into care? What makes people fall out of care? And there are a number of different reasons why people do that. There might be personal circumstances, social circumstances, stigma, etc. But then the most important thing is they need care in a place of safety and a place where they can feel safe to be able to get that care. And I have to say, for me, what is crucial is that care needs to be delivered locally. In other words, I don't want people to travel 100 miles to their nearest clinic so that they can get antiretroviral therapy. I want them to have their care as close to home as possible in a safe, secure, warm, friendly environment with people they know, people they can relate to. And so I think for us, the most important thing that we've done in our clinic is introduce peer support, because that is so crucial. It's like, these are people that I know, these are my people, and I feel safe here. So there are many examples of many things that we can do, but we do need to kind of re-engage those that have been lost.
We are getting really good results from a project that we've just done. So we're coming up to a year now of having an engagement support worker that was funded by the local authority, so by public health, because they know that if then we re-engage those people and get them to an undetectable viral load, then we're going to stop transmissions, or it's going to aid us to help stop. And it is all of those factors that actually, when you talk to them about their HIV, they're actually okay and they're fine with it. It's all of these external life factors that they've got going on, which has just meant they don't see right here, right now, that HIV is their priority. And we have a dedicated worker who works full time and provides real intensive support to those clients, calling them daily, reminding them when their clinic appointment is, attending clinic with them. He is a peer as well as being a professional. So it's all of that. And it's, we've got really good kind of results from this kind of year pilot that we've done, and we're hoping to kind of continue that now.
And this is so important, because if you look at the data in terms of this kind of aim of getting to 2030, there are more people in the UK who have been previously diagnosed with HIV but fallen out of care than there are people that have HIV and don't know it. So testing is crucial, but it's not at the expense of. And I think it's easy to forget the thing, because in a way, you've just described it brilliantly, but it's not a simple thing, supporting people back into care. It's not like a cheap, easy intervention where you're like, we'll just do this thing and we'll get this person tested and we'll send them on this pathway and it will all be sorted and we can tick our box. It's a real person with a complex life and with priorities and things that are difficult, and they, and having no money and having mental health issues and struggling with children and being in violent relationships and all the things that mean that HIV is the bottom of the list.
And the best people that are best placed to do that is as third sector organisations. We are the best people in that to be able to kind of fill that gap between like clinician and treatment. And it is that dedicated funding, and it is that dedicated resource where a third sector agency can just go in, like get their intensive support worker in post and be able to do that work, and it will not take that long for you to get results, because you can find them, and really good, we're lucky, we've got really good ties with our clinicians as well. So they did the research, they did this, the Hunt study of finding who those people are through their system, and then passed that data on to us, and we're part of the MDT with them, and it is this collaborative approach between clinic and us that are able to get the results that we're getting.
And it is money, but it's less money than I think the NHS would pay to employ itself. So it's better value for
100%.
For the NHS as well. So and again, if you don't help people, they will turn back up in clinic or in acute crisis and cost
more.
an awful lot of money in terms of the interventions that they need. So we're in London again. We've just agreed to start scoping. What would happen if we suddenly found, a large amount of money to do both?
You found some money before.
I was going to say, London seemed to be very good at finding money.
Last time no one thought I could do it. This time, there's much more pressure this time. But to say, well, actually, if we did peer support as a whole for people who are both newly diagnosed and lost to follow up, and we created that with everyone working together, again, because we've built that trust, we've got that community, what does that look like? And actually, if we had this much money, what could we do? And if we had this much money, what could we do? And that is all about engagement of the third sector. It's all about the NHS. It's definitely the way to go. There is no, I don't think there's any doubt in anyone's mind. It's just about enabling it and making it happen somehow.
Hopefully, with some of that money, we can pay some of the nurses a bit more.
Thank you. Yeah, everyone watching.
Sort out the GPs, the nurses.
That's fine.
Sort out
You
the
keep your
recruitment
list.
in the NHS.
Yeah.
Yeah,
You keep
okay,
your
fine.
mental.
Yeah.
I've got-
Your list.
Yeah.
The power of peer support doesn't really, like, it. We could talk about the power of peer support until we're all kind of like blue in the face
Yes.
with it. Like, peer support is incredible, and so much so that at Brigstowe in Bristol, you know, we've had our local commissioners ask us to adapt our HIV peer support model because of the results that we've had there to deliver to other long-term health conditions. So now, as an organisation, we are selling our model. We actually sold a model for long COVID peer support to London for once, which never happens. I was like, yes, look at this, we've made it. London are asking us for something rather than the other way around. So we've got like long COVID, type 2 diabetes. The university is asking us to do a trans and non-binary project with them. We've helped women ex-offenders with peer support. Peer support is something that can be modelled across absolutely everything. And the people that started that was the HIV sector. And it just shows that if you actively engage people with their diagnosis, with their care, with their treatment, with peers who have been there, done that, and you've got that dedicated time and space to be able to talk about all of those things, you are just going to naturally see results without even trying. And I could talk about our peer mentors. I used to be a peer mentor, but I could talk about our peer mentors like forever, for the whole hour probably, but we haven't got time, but they are amazing.
Research from Dr. Rageshri Darawan and colleagues in London found that people from black communities were more likely to fall out of care, more likely to have viral rebound. How much do you think racism is a significant factor in that happening? I'll start with
Susan, I don't have 2 minutes.
in your 2 minutes. How long does it take?
So I guess a lot of it has to do with representation. I know Aisha will back me up on this. And it's one reason why we wanted to look at getting the RMC SIG pop through BASH, so that there's a set plan as to making sure that these communities are looked after and are not left behind. I think a lot of it is due to the rates of STIs in the Black Caribbean and Black African community have been ridiculous since the 50s, 60s. And it's just year on year, it's the same thing over and over, and there's no change to it. All these interventions happen for men who have sex with men to reduce HIV transmission. But the black community is always left behind, but we also know that they're a community that are suffering. So I think it's just about, there's a lot of work that needs to be done to make sure people feel accepted, feel represented. I think
that racism definitely plays a part in terms of the fact that you're looking at a community that are already stigmatised just for existing, just for breathing, and just for going about their business in the UK on a daily basis. If you add into that the stigma that comes along with either a HIV diagnosis or being seen to be testing for HIV, or for being, quote unquote, sexually promiscuous, as some people will think that people are if they're engaging with sexual health services in particular communities. When you add all of those things together, it becomes another thing for black and brown communities to have to be thinking about. And for me, we're tired is number one on the list, but also I think that we've got to the stage now where not only are we tired, we're also becoming more and more activist-y, if you like. So we're getting to the stage now where we're like, actually, no, that's not okay. And that's one of the things I think the Common Ambition Bristol saw when we did our research at the beginning of our project, was we spoke to communities and we were like, right, okay, why are you not engaging with services? And it was like, well, why should I queue up just to be made to feel other when I walk in the room? And those were the actual words that people were saying to us. And it's like, okay, so we had to make sure that when we set up our project, as you said, representation matters, top down, bottom up. Our clinic, for instance, that we run once a month is Bristol's only walk-in service. It's also the South West's only service for people of African and Caribbean heritage communities. And we have a black nurse there. Since we've had a black nurse, we've seen numbers rise. And that's because we have a black nurse, we have a black admin, we have me, we have Common Ambition Bristol there. So people are feeling more at home to be able to come in and to test. And then I think that, as you said, that needs to continue. That feeling of belonging needs to continue through services, bottom up and top down. You know, there needs to be that representation throughout.
And I think as a sector, we need to start reframing more, like stop calling those communities hard to reach, because by saying that, it makes it sound like we have to go through some sort of ninja warrior style obstacle course to find these communities to provide interventions to them. They're not hard to reach, they're here.
We were here before everyone else.
Just engage them and engage them from the start.
You know, absolutely. And Debbie, NAT have played a really important role in persuading the government to have treatment free of charge to people regardless of their immigration status. But what's the situation in terms of migrants in the UK now? What have you found?
Yeah, I mean, that is one really important building block, but it is so far from being everything that's necessary. And you're asking me this, I assume, because we published a kind of big piece of research a year or so ago about HIV and migration, and we know that migrants to the UK are both more likely to be diagnosed with HIV. The majority of people diagnosed with HIV are migrants, the majority of people living with HIV are migrants, but they're living in a massively hostile environment in which, first of all, there's an enormous amount of racism targeted at migrants. Then there's an awful lot of blame, unfactual blame, suggesting that people are here for kind of health tourism reasons. Data shows that's not true. The vast majority of migrants who are diagnosed with HIV acquire it in the UK after they come, or if they did have HIV before they came, the average amount of time it takes them to access healthcare, 3 to 5 years. So that is not somebody that's travelling to the UK to get healthcare. They don't know how to get healthcare when they get here. It's brilliant. We're really proud of the fact that people can access free treatment for sexual health, for HIV, but they can't access the rest of the health system. And you can't divide people. You know, we all know the kind of complexity of comorbidities with HIV. You know, it's not that helpful if you can get free treatment for HIV, but not for your diabetes. You know, or not for your heart condition, or not for any of the other things, not for your mental health difficulties. And then there are issues around fear of accessing things like GPs because of the way that data has been used in the past to trace people who have insecure immigration, so that they then are frightened of even going to a GP in the first place. Language barriers, sorry, I could go on and on. But so that free HIV treatment, that's great, but we're nowhere near where we need to be able to enable migrants to get the healthcare they need and deserve.
And sorry, just as an add-on, it's great that we do have free healthcare for anybody at the point of access in terms of HIV treatment, regardless of immigration status. But then what we need to think about in those areas or in those cities is, it's great if the treatment is free, but how are they going to get to clinic to access that treatment?
Absolutely.
Is the clinic actually accessible? Can they afford the day ticket on the bus to be able to get there? Are they able to actually engage in their treatment because of the cost that it costs them if they've got a family and they're just living on the standard?
Yes, Sanjay.
So Susan, can I take us just one step back? There's an old adage in infectious diseases is that no one's safe until everyone's safe. And I cannot let this go, because I'm the president of the European AIDS Society, and on our doorstep in East, Central Europe, Central Asia, we are nowhere near, you know, the 2030 elimination targets. I mean, you know, less than 70% of people in some countries have been diagnosed. And so whilst, wonderful advances that we made in the UK, I also need for us to be able to think about how we're going to tackle this globally.
Absolutely, and UNAIDS has highlighted in the In Danger report that progress has actually stalled. And what's really concerning is that the UK government, it looks like funding to the Global Fund is actually, it's going to be less.
It's shameful that we're
Yes.
the only country,
Yes.
other than Italy, in the world that has not yet committed funding to the Global Fund replenishment, and that it's looking like it's going to reduce when the rest of the world
Yeah.
are increasing their funding.
So as a campaigning organisation, what can people do to put pressure on the government to change this, Debbie?
No pressure. I mean, this is, it's shameful, and it's part of a massively bigger problem in the UK in terms of what's happening for funding for international development.
Yes.
But I guess now is the time. Write to your MP, write to the Treasury, write to the
Vote.
Sorry?
Vote.
Vote, absolutely
Yes.
vote. I certainly would not, as National AIDS Trust, tell you who to vote for, but maybe look at the history of supporting these kind of things when you make those choices.
And I also think that it's a really important point that we
Protest.
make in terms of when we're looking at the global picture and the effect that the global picture has on stigma within the UK, particularly for Black and Brown communities, particularly for African and Caribbean communities, African especially. You know, a lot of people's experience of HIV is in a very different context to what we see here in the UK. I'm of Ugandan heritage. The picture in Uganda is very, very, very different. So, you know, for people like my father, like my family, who would have experienced HIV and AIDS on a completely different spectrum, that stigma comes with them when they come to the UK, and then it comes on to their children like myself, and you know, so it's really about making sure that, you know, we acknowledge that and do the work that we need to do to tackle stigma within communities here that would have faced a very different picture at home, because it's so important. We're not going to get the engagement with services when people are still terrified from what they've seen at home, and we're not helping by pulling back our funding to make the situation at home any better.
Colonisation.
Yeah, absolutely.
There is something about so all of that is totally accepted, I think. There is something though about how well the UK response has done that's also important in that lobbying, because there's the outrage, there's the, you know, we need to get, if this doesn't happen, this won't work, but there's also, you know, the UK has done historically very well because of the basis in activism, and things have changed because you have changed them.
In certain communities.
Yes, but they'll still only be changed by those communities. Yeah. But I still think there is something about, you will not get to elimination. The viruses, all the bloodborne viruses, don't care what your politics are.
No,
they don't. Yeah. So if you want to eliminate it, you have to treat migrant populations as human. That is
first
basic.
And foremost.
And you have to, but also there is something about how you could show the good that has been done here through that activism, through that lobbying. Again, take credit for it, because it's so, you know, enraging in the moment, I think, to not have these things happen. But I think that's also something that can help our lobbying. You know, the UK should be, and it is something that the UK can be proud of. And there's not a big list that I can see at the moment of things like that that could be helped around how we push this internationally. And that's certainly where I'll go.
Yeah, absolutely. And if we can move on to PrEP, you and AIDS have highlighted today how woefully inadequate it is, that the number of people that have access to PrEP globally. Sanjay, can you tell us about the different types of PrEP and where it's available?
So, firstly, PrEP is part of your combination prevention therapy strategy, and PrEP stands for pre-exposure prophylaxis. And the whole concept here is that you use medications that get into your genital tract before you're at risk, and so once the virus gets in, it doesn't get established, it aborts infection. And this is a really clever concept and has been tried and tested over many years now. So, you know, we have a few different types of pre-exposure prophylaxis that we can use. So traditionally it's the tenofovir-based regimens. For men, this can be event-driven. In other words, you know, you can take 2 tablets of PrEP 4 to 24 hours beforehand, and then 1 each day afterwards. For women, this needs to be daily, because getting into the genital tract of women takes about 7 days to achieve. And so it's a lot more difficult for women. So there's other things that we've tried for women. There is the ring PrEP, and so this is the cervical ring that sits in a vagina, releases medications into your genital tract and prevents infection. That's pretty effective. And more importantly, recently, what's been really fantastic is injectable long-acting PrEP. And so this is carbotegravir, which is an injection once every 2 months. and that can be used as preventative therapy. The WHO have just released guidelines to say this is what is acceptable, and I know there are a handful of countries that have just started to get the ball rolling in terms of getting this approved for use. Unfortunately for us in the UK, it is just an offer-based PrEP at the moment.
Right. And do you think if PrEP was available, if you could get it like pharmacists or the GPs, do you think that uptake would be better, particularly for women, Aisha?
I think that it would. I think that, you know, we've already discussed, and I think we realise as a sector that it's not just about what's available at sexual health clinics. It's at the moment, sexual health clinics are very stressed. You know, we know that the services are quite stretched. Getting appointments in cities like Bristol is not easy. So, you know, that's why walk-in services like we run are important. But I also think that it's about looking at the other options for people, because we've already talked about Black communities being left behind. How are we to engage people, even with long-lasting PrEP, if we can't engage them at the moment with the PrEP that we already have? And for women in particular, it's really about hitting that message home about why it works for you, why we're trying to get you on PrEP, why it could be something that really is a game changer. Because it's not, you know, we've seen it be a game changer for the sector. It was a game changer within gay communities. It's a game changer for any community. And that's the message we need to be getting out there. And I think that the more and more we can engage women in thinking about sexual health in general, as I already said, and engage them about thinking about PrEP, and the more we can offer that in places that they can access, the better the uptake is going to be. We've seen that at clinic already, in terms of we've already started somebody on PrEP within our clinic who is a woman from an African background. So it's important to be able to provide it in places that people want to come, like to come, will come. And whether it's pharmacies or chemists or community services, or using the boots on the ground organisations, the third sector organisations, to let people know, you know, this is safe, this is for you, this is why it's for you. Come to us and talk to us about it. Let us explain it to you. Really engage with services, and let our services engage with you in how to make sure that you know that this is for you. And no, you're not going to have to wait 6 weeks for an appointment before you can get it, and then another 3 weeks for the test results to come back, and then another 2 weeks before we can prescribe. Come to us and just get it.
It's all about normalising that conversation around sexual health, and like community pharmacies and GPs are the way to do that. And they already have been invaluable in terms of either flu jab rollout or COVID vaccine rollout. So they can deliver vaccines if they're long lasting, because they have got a record of it. But they do need to be educated. It was only this weekend I had someone in Bristol get refused a flu jab because they were on PrEP, because the nurse didn't understand what PrEP was. So that's in my in tray for when I go back to work tomorrow, to contact that pharmacy and sort it out. But it is just all about that normalisation to be able to increase it, and seeing that sex is just a holistic part of your healthcare, and not just for something that you have to engage in as and when you decide to have it.
Yeah, absolutely. And what's Dean Street doing in terms of PrEP Awareness Week to raise awareness of PrEP?
I can't talk too much about what we're planning to do, but I'm involved in the steering committee for PrEP Awareness Week. So last year they had some celebrities posting about PrEP, their use of PrEP, and advocating for it, doing pop-ups in different community places. So they did it in different gay establishments in Soho and other places. So a couple of my colleagues have been brought on to access the racially minoritized community sector, so to ensure that it's not just all about the gay men. Like, you know, it's not, the research is there, let's start looking at the black people, the brown people. So we're just, PrEP Awareness Week is coming up just before, I can't remember what it's called, what's December?
World AIDS Day.
World AIDS.
Yes.
So we're going to do lots of stuff, so social media, and hopefully some of the other clinics also will get involved in London as well. So if you want the stuff, come to
fantastic.
me. Okay.
And Debbie, kudos to NAT again in actually making PrEP available. But what's your research showing now about uptake of PrEP?
Yeah, so we have a report coming out on Thursday. Watch this space. So they'll kill me if I give away too many of the headlines.
Yeah.
But in summary, unsurprisingly, probably for all of us around this sofa, what it's showing is some of the real difficulties there are practically in accessing PrEP where it is now. So real differences geographically around the country, real differences for different communities, sometimes very long waits to get on waiting lists to be able to see it, very long waits to get appointments, real kind of differences in levels of services, and all of that complicated and difficult in the first place, and really I think supports the call for PrEP to be available in other places. You know, for women should be able to talk about PrEP when they're talking about contraception.
Exactly.
You know, it's part of that same conversation. So I think it supports all of that. I've totally lost track of what I was going to say.
So I was going to say, like, also like maybe a standardised approach to delivering PrEP, because I know that, for example, in my service, we will start you on PrEP the day that you arrive, regardless of your results.
Yes.
And what that means is that if you have had risk or you plan to have ongoing risk, that we're going to hopefully prevent that before you do become positive. Instead of saying, okay, you need to come test, it's 3 weeks, 4 weeks for a test, then you have to wait a week for your results, you have to book another appointment to come back and collect your PrEP. It's just guidance.
Like a national PrEP service with online testing that takes the people who are less complex, that don't then need to go into the clinic, so that then the people that need to really sit down and talk to somebody can get an appointment. There are solutions that are kind of available.
The last thing we want to
really
see,
tricky.
the last thing we want to see, which I know has happened, is somebody calling the PrEP line for a clinic, waiting for their first appointment for their assessment, and within that time
they become positive.
They've become positive. Yeah, at the beginning they were actively trying to seek
I've seen it a lot.
a prevention measure, and it is sexual health and the clinics, and it's the constant fragmentation of those services, the constant decommissioning, the constant
changes,
taking away of funding but giving more to those clinics, especially with monkeypox being the first sector they're going to deploy staff because everybody thinks we're in a lockdown and nobody's going to have sex. Joke. But like, it's that constant taking away but adding extra pressure where they've got to then try and deliver a PrEP rollout, and you've got maybe 3 health advisors, 2 nurses, and they're trying to do everything else, and somebody's waiting 6 weeks just for an initial appointment to then wait even further before they even start it.
Absolutely. Well, we've only got 8 more minutes and we're getting some questions through, but I want to touch on monkeypox. What has been the impact on sexual health services?
It's been huge.
It's been huge. BASH has published data that shows that in a number of clinics it's displaced around 30% of activity, so that's an average. So that means to get to that 30% average, there will be many clinics where it's displaced an even larger, I mean, I guess you can talk about this, but just across the system very briefly, it's meant that people can't get appointments for PrEP. They can't get appointments for LARC. They can't get appointments for being diagnosed with HIV. They can't get appointments for HIV testing. And that is having a massive impact. And clinics are desperately doing amazing work, diagnosing, treating monkeypox, doing the rollout of vaccines. And they're doing all of that with no funding. And it is a system disaster that urgently needs.
We kept asking for lots of support to make sure we can increase activity but also support the monkeypox rollout. Now, a lot of clinics hopefully are running it within their normal service because of the numbers being so low and the experience, but I was redeployed, some of my colleagues were redeployed to go help with the monkeypox pandemic, and it meant that other services were reduced, and the same thing happened in COVID where first they got rid of LARC services and they said you can go on the progesterone only pill when that's not acceptable for some people. So we fought very hard to make sure that we were able to keep services running, but we also had to make sure that we were able to support the monkeypox rollout. Monkeypox at the very beginning, it took a long time to diagnose and it took a long time to go through, and they had other co-infections at the same time. Cleaning the room. It was just madness. And then that also meant that we had to decide, okay, well, how are we going to adapt? Now, Dean Street did something really great where they basically were like, you can just walk in for PrEP. If you're under 21, you can just walk in for PrEP. And they were just like, here, take PrEP, go do an online testing kit. Perfect. So we adapted really quickly, and I think because of COVID, we were able to adapt and be like, okay, well, we need to make sure our patients get what they need. Let's just, here, chuck it, then we'll deal with the repercussions later.
It's just going to be another year of skewed data though, isn't it? When we're looking at new HIV diagnoses or diagnoses of other sexually transmitted infections, and we're either seeing them increase or we hail that it's another decrease, and then we go, but why is it decreased? Has it decreased because we're not testing?
Exactly.
Because people can't get to a testing service to be able to diagnose them, because we can only diagnose a positive if they've tested.
Yeah.
So it's just another year, after 2 years of skewed COVID data with new HIV diagnoses, that we're getting another year of skewed data because of monkeypox. And it's like, it's that data that then drives funding to clinics, to third sector, to actually be able to call an action that we need resource, because everybody's going to be like, oh, yay, congrats, it's a decrease again. But it's not a true decrease, is it?
You know, absolutely. And we've got 5 more minutes, and we've got some quick answers to some of the questions that have come through. Sanjay, I'll pose this to you. Do you think new injectable treatments will help get to zero HIV transmissions by 2030?
It's part of the strategy. I am not sure that new injectable treatments are any better than the one single tablet a day that most people are able to take. So the answer to that is probably no, but it's part of the treatment strategy.
Okay, and Debbie, the UK government has become more hostile to migrants. Do you think this will hamper the HIV response?
Yes.
Yeah.
Yes.
Great answer.
You said it was a quick fire.
Yes, yeah.
Yes.
No, absolutely. And over to you, over onto this side. How much does the U equals U message help people to stay on treatment?
A lot.
A lot.
A lot.
A lot, a lot, a lot. It really does help. And for a lot of people living with HIV, the last thing they want to do is think that they're going to transmit it on. But at the same time as it does help, at the same time, we don't need to place somebody's value on whether they have a detectable or undetectable viral load, because we know that some people can't get to that. So yes.
So I have some patients tell me that, oh, my HIV is not my biggest problem because I'm undetectable. I take my tablets like my vitamins, done.
Yeah,
perfect. And that's the second nature.
Absolutely. And Ian, how important is the Fast Track Cities initiative across the world in helping us get to zero?
Across the world.
Well,
we've got Copenhagen.
Yeah.
I think it is really important. I mean, it's a way to gain some additional international credibility for different places' responses, and to network and to make sure that we're doing the right things that are available to us, and that will be different from country to country. So I think it is a really important way of us saying we're working together as a city or municipality to solve the problem. So I do think it is important. Yeah.
And Sanjay, how can we eliminate vertical transmission of HIV? Really good, in like 1 minute.
Like 1 minute.
In 1 minute.
Test services for pregnant women, interventions to prevent mother-to-child transmission, please.
Yeah, absolutely.
And this should be absolutely opt-out for antenatal testing everywhere in the world.
Absolutely. Fantastic. And we've got 2 more minutes, and I would like to pose a question to all of you as a quick fire question. One action needed now to get us to zero HIV infections by 2030, but we'll go around starting. If you had to pick pick one thing.
I refuse to buy in to your question, Susan, because there isn't one thing. And all joking aside, that oversimplifies what is genuinely a kind of complicated thing, I guess.
But we can go around.
One thing is that a level of political support starts at the beginning. That then makes the laws change, it makes the money be in place, it makes the pay be right for the nurses. So it's a political support and accountability.
Over to you.
Representation.
Fantastic. Aisha.
I would say the same, representation, but for me it's also about it. Along with that representation, make sure that you are bringing all of the intersectionalities into that representation. And then,
One word.
It doesn't have to be one, but briefly.
Well, if we have an action plan, it needs to be a national action plan that has equitable access to resources, capacity and funding. And that probably stems to Deb, which is political.
Absolutely. Over to you.
Go on,
Yeah, over to you.
Go ahead.
So mine is because it can be done. and what an amazing thing that would be to be part of. So it is political, but it's on the basis that we know how to do it, or we can get there globally, but that we need the political will to be able to do it, to give us the tools to do it.
I want it to be a global ambition.
Yes.
Yeah, so let's make it not just the UK, for all of the world. Let's get to zero by 2030.
Fantastic, and what a perfect way to end this discussion. I'd like to thank you all so much for taking part. I'd like to thank the brilliant Disruptive team for doing their technical wizardry. Thank you. I'd like to thank our lovely audience from Copenhagen. Everyone who's watched today, thank you all so much. Thanks. Bye-bye.
Thank you, Susan. Thank you. Do we get wine now?